This section, which we call physician-patient relationship, is unique in your exam preparation. Because the issue here is not so much things that you memorize. The issue here is really attitude. It's really about having the right approach and seeing things the right way and having the right sensibility. Some people find this, frankly, the easiest part of the exam because you just happen to be calibrated exactly to where you're supposed to be. And so you read a question, you see the option, you say, well, of course, the answer is A, and you're right. Other people find this to be the absolute hardest part of the exam because they read the question, they look at the options, they say, of course, it's A, and they're absolutely wrong. And since it feels so right, it's hard to get a sense of why that's not the acceptable answer. What's right or wrong on the exam is not about what I think is right or wrong, and not about what you think is right or wrong. What's right or wrong in your Step 2 CK exam is what the question writers, what the examiners collectively have decided the right answer is. And so, as we get ready for these questions, let's calibrate ourselves to where we have to be. It's not about what we believe is right or wrong, it's about what the examiners will give us a point for saying. That means if you're reading through these questions, you say, well, the answer is clearly B, but I bet they want me to pick D. For God's sakes, pick D. Your job here is to give the answer that the examiners want in order to glean the point that's available from the question. Now, once again, this is about attitude. I'm going to go through trying to give you a way to get a sense of that attitude, and I'm also going to give you some rules that help to guide you as to what the right attitude is. As we've done for ethical legal issues, once again, I'm going to give you 20 rules. Now, I confess, we didn't start off to have 20 rules. It just worked out that way. I don't know why 20 is the magic number, but it does seem to be here. Your job on these questions is as it was on the ethical legal questions. Your job is to read the case, think about what the rule is that applies, and then answer the questions based on the rule. Please, never tell me an answer unless you can tell me what the rule is that justifies the answer. That's the way to train yourself to make sure you are in fact calibrated for the exam. It's not that your instincts are necessarily wrong, it's just that your instincts may not be right for what the examiners want you to say. And so, to try to get you tuned in to where you're supposed to be, what your sensitivities ought to be, how you're supposed to be reading things and thinking for the exam, we have rule number 1. Rule number 1 reminds you that the patient is number 1. The exam is not about you, it's about your patient. Given a choice between you suffering and the patient suffering, who gets to suffer on this exam? You do. Given a choice between your convenience and the patient's convenience, what do you choose here? You choose the patient's convenience. It's not about you. It's about making sure the patient gets the care, the attention, the service, if I can use that term, that they deserve. Please stop thinking about legal issues here. Please stop thinking about how you're going to defend yourself legally in front of a patient, or think about how you're going to justify your actions. Your job is to deal directly with the patient as well as you can and come up with the best plan of care and then go forward after the patient has agreed. The patient is number 1. They're in charge. You're not. Number 2, that means always respond to the patient. If the patient asks you a question, answer the question. Anything else can't possibly be considered a right answer. If a patient asks you a direct question, your job is to provide a direct answer. If the patient says, "Doctor, am I going to die?" and you think they are, the right answer, of course, is yes. Not, "Well, we're all going to die sometime," or not, "Well, we're going to make sure that doesn't happen." We expect truth-telling so we can receive truth in turn from the patient. The idea here is crucial. Your job is to be an information sponge, to collect as much information as possible about the patient's condition and the patient's life. If you want your patient to tell you, then you have to make sure you tell your patient. Answer the patient's questions. And when you're answering the questions, don't only respond to the cognitive content, respond to the emotional content as well. Prior to going to surgery, the patient says to you in a shaking, quavering voice, "Doctor, what's this surgery about? Will I be okay?" Well, the right answer is not simply describing the surgical procedure in technical detail. The right answer is dealing with the patient's need, their desire. They're asking for comfort and reassurance. Number 3, tell the patient everything. There's a game in the real world you sometimes see physicians play with patients. The game is, they didn't ask, so I won't tell. Wrong. Your job's to tell the patient everything, even if they do not ask. The real rule is, whatever you know, the patient should know, and as soon as you know it. That means any suggestion that you delay, wait, don't tell them today, tell them tomorrow, those are clearly, if you have the right attitude here, all the wrong answers. If I know, my patient should know. Stop thinking about your patient as a helpless child that needs to be protected. The right way to think about your patient is they're a fully fledged partner in the healthcare enterprise. You know things about health, physiology, pathology, disease. They know things about their life, their family, their situation. It's the combination of that information together that arrives at the best diagnosis and certainly the best treatment plan. What if the patient says, I don't want to know? What if the patient says, look, doc, if it's cancer, I couldn't take that. I just don't want to know. Well, the option you see that says, okay, I'll respect your wishes, is not right on that one. The option you see that says, okay, who in your family should I talk to, is not right on that one as well. Because, well, for your patient to make treatment decisions, they must be fully informed. That's what informed consent is about. So clearly, the patient has to know. But the option that says, I'm sorry, I'm required to tell you the results, is simply too harsh, and therefore not right either. Let me frame it for you this way. When a patient says, I don't want to know, that's not the end of the conversation, that's the beginning of the conversation. The right reply on the part of the physician is, tell me more about why you don't want to know the diagnosis. You're going to forget about the diagnosis and now have a conversation about what the patient wants to find out and why they're afraid of getting certain information. What if you don't know everything? What if the patient says, doctor, do I have cancer? Well, at this point, when the patient asks that question, you've already run 2 tests. One, a screening test suggesting the patient does have cancer, but you're waiting for the definitive biopsy to come back tomorrow afternoon. When approached by the patient and says, Doc, do I have cancer? What's the right reply? How about, yes, we did run a test suggests you have cancer. Probably not the best reply. There's more going on here. How about, I'll know more definitively tomorrow afternoon? Yeah, not the best reply either. The right reply is, I run 2 tests. The preliminary test does indicate you have cancer, but I'm waiting to see whether or not that's confirmed with the test tomorrow afternoon. In other words, you tell them where you are in the process. It's not just about finishing, getting to the end point, and then telling them where you end up. You take them step by step through the process. And frankly, the fact the patient had to walk up and ask you the results when the screening test has been done clearly means the patient was not treated the way they're supposed to be. You knew the result. You should have told the patient the result before they even asked. Number 4, work on developing a good long-term relationship with the patient, not merely treating the acute medical problem. This is an issue where a number of students think they got the question right and in fact got the question wrong. Because you read down through the case and you recognize the exact pathophysiological issue. You nail the diagnosis. And then it says, what should the physician do next? And there you see it. The right treatment for that particular diagnosis. You've studied it, you learned it, you feel good that you remember it, and you mark that answer, you move to the next question, and you got your question wrong. Because, well, although you did treat the condition appropriately, you didn't succeed in everything you're supposed to succeed in that moment. Every encounter you have with the patient is supposed to be a chance to develop a better relationship with the patient. If you merely treat their medical condition and don't emerge with a better relationship, so the examiners hold, you have failed. It's not about simply getting them better, it's about getting a better relationship with them. And so you're looking for an option that achieves both of those goals, not merely the right intervention, but the right intervention that gives you a better relationship. What are some simple things to focus on that might give a better relationship? Well, there's some clear indices. Eye contact is always a good idea. Choosing between options, one which has you looking the patient in the eye face to face, another which has you off to the side or talking to them over the telephone, you know what the right option is. Face to face is always better. Define touch. Is it all right for me to touch my patient? Sure, as long as they realize what I'm doing. When you do your physical exam, you're always supposed to verbalize what you're doing. It calms the patient, helps them not be surprised. You don't surprise them with the stethoscope. You talk to them about what you're doing before it happens. I have a female patient in her early 30s. She just lost her husband in an automobile accident several months ago. She's in my office now for a medical problem, and she breaks down crying rather uncontrollably. Is it all right for me to put my arm around her to provide comfort? Yes. That's a perfectly normal human response. And we want you to have perfectly normal human responses. But there are, of course, limitations here. It's probably not all right to give my patient a full-body hug. That might well be misconstrued and therefore is clearly over the line. And if you're in the room with a patient, you should be focused on and you should be talking with the patient. If you're in there with a patient and the family members, your conversation should be to the patient, not to the family members. If you're in the room with a set of medical colleagues and the patient, your conversation should be with the patient, not with your medical colleagues. Any conversation with colleagues where you want to discuss the technical issues involved in the patient's condition, that should happen outside the room, out of the earshot of the patient. And by the way, should probably not be in the hallway where you could be overheard by people passing by. You're doing morning rounds. You, a second-year resident, 2 other residents, an attending physician, a couple of medical students, and a visiting surgeon from Sweden. You all walk into the patient's room, stand in that little semicircle around the patient's bed, and the visiting surgeon asks you a detailed question about your patient's health condition. What's the right answer? That's obvious. The one that has you ignoring the surgeon and interacting with the patient. Anything else can't possibly be considered best. Now, is that what happens in the real world? Of course not. And I remind you, the exam is not about the real world. It's about the ideal physician. Forget the reality. Think about what the most ideal physician should do in order to guide yourself to the proper attitude here. I made, in that example, the physician, the surgeon from Sweden, because the research I have in mind was actually done in Sweden. There at a hospital in Stockholm, they noticed a mortality spike following morning rounds. Doctors would walk in, talk to patients, do morning rounds, walk out, boom, patients would die right afterwards. Well, they sat down and assessed the situation and decided that a bunch of white-coated people standing around the patient talking about their health condition using long Latin phrases introduced anxiety into the cardiac patient. And as you know, anxiety in a cardiac patient is not a good mix. So they had put in place the solution I'm suggesting for your exam. Namely, if you're in the room with the patient, you will deal with the patient. And with this intervention in place, the mortality spike went away. Now, I tell that story to underline for you why we have these rules. It's not about being polite. It's not about being nice. It's about getting the best possible medical outcome. When you treat the patients this way, when you do the things we're suggesting, you get more information, you make better decisions, and you get better recovery and survival rates. Number 5, listen, reflect, encourage. Simply put, given a choice between an option that has you talking, saying something brilliant perhaps, and an option that has you encouraging the patient to talk, you know what's the right answer in the exam. Anytime the patient's talking, you're learning something. And I say again, you ought to be an information sponge. Hearing from the patient ought to be a preoccupation. Anytime you're talking, you're learning nothing. We look in research at the physician-patient interaction in the real world. We find the physicians talk 75% of the time and the patients talk 25%. On the exam, reverse those percentages. You get 25, they get 75. Focus on getting the patient to talk to you. You should hear what their life is like. You should hear what their concerns are. You ought to develop the active listening skills of reflecting, repeating back what you've heard, showing sympathy, nodding your head, eye contact, good nonverbals. All this you know in your better moments is the right thing to do. All this I must try to get you to think about doing when you're answering your exam questions. If you're in the room with a patient, your staff feels long enough with the patient. They're knocking on the door, telling you it's time to move on to the other patients you have waiting for you. But if you're not done yet with the patient, the right reply, of course, must be to tell your staff you're not done. It's going to take you a little while longer, and to sit down, if you were standing up, leaving, and talk with the patient again, of course. It's crucial that the patient feels like they have your full concentration, your full attention, and as much time as they need. This is especially important because, well, every primary care physician will tell you about what we sometimes call the doorknob questions. This is where the patient comes in, presents a problem, you talk about, you deal with, come up with a treatment solution for the problem, and then as you're getting up to leave with your hand on the doorknob, the patient says, "Oh, doctor, there's just one other thing." And every good primary care physician worth their salt knows that's the reason why they really came in to see you. The initial problem was merely a Trojan horse, was a dodge, was just then feeling out whether they're comfortable with you, and now this is the issue they really came there for. This happens not infrequently, this happens a lot, and the right reply when they hit you with the doorknob question is to take your hand off the doorknob, sit down, face to face, and have the conversation about whatever it is the patient wants to talk about. What about all your other patients that are waiting for you? They will get the exact same attention and conversation from you that you are giving to this patient when it comes time for them to see you. Listen, reflect, encourage. Listening, hearing is better than talking. Number 6. Number 6 is the core attitude item. Negotiate rather than order. Your vision of medical practice is the white-coated doctor as the general, clipboard under the arm, walking into the room, surveying the scene, barking out orders, expecting to be saluted and obeyed. You're going to get every one of these questions on your Step 2 CK wrong. The right orientation is one of negotiation, of reaching agreement, of generating a compromise. When we survey physicians in the real world, one of the things physicians complain about the most is, quote, "My patients don't listen to me. I make an agreement as to what they should do with treatment, how we should do follow-up, and they simply don't follow through." Well, understand it's your obligation to find a way to get them to follow through. Telling them the right thing and bemoaning the fact they don't listen is not an acceptable outcome. You must solve this problem. And I have to tell you, one of the easiest ways to solve the problem is make an agreement, make a contract. The way most people are wired, we don't like to be ordered around, but we honor our agreements with other people. When the doctor says, "This is what I want you to do," that's not very compelling to many people. When a doctor says, "Now, here's what we've agreed to do if I understand, I'll do this and you do that, and then we'll meet back here and see how it's going," people feel much more compelled to hold up literally their side of the bargain here. The way to get adherence, the way to get rid of the frustration that non-adherence brings is to make this particular contract. It's not just about you commanding the patient. They're going to do something, you're going to do something. The joint effort is what provides success. Number 7, you have to respond to new information. You have to respond to, well, new people that appear on the scene. Step 2 questions can seem, and they frankly are, fairly long. One of the things that happens as you're reading through a Step 2 question is it goes off in a direction you weren't expecting. It's very common to be reading down through the question, thinking about one set of issues, and then as you get down towards the end of the question, it suddenly careens off in a totally different direction to be dealing with a totally different issue than you anticipated. It's important that you change your response and deal with the new information presented. There's an issue here that I sometimes call a momentum issue, and I'll give you this as an adjunct rule here, which is don't get carried away by the momentum. You're reading down through the question and you made a plan. You've assessed what's wrong. You have a plan about what action you're going to take and how you're going to deal with what's presented. But then something new is presented at the very end of the question. What they're testing you on right there is simple. Are you flexible? Do you change? Do you adapt? Or do you simply march ahead and complete the plan that you originally had? If you complete the plan, even if it's a good one, you clearly got the question wrong. Because as the information and the personnel change, your behavior must change as well. Here's the prototypical question that I'm thinking about. Well, the lab values have finally come back, took long enough, and your worst fears are realized, your patient does have cancer. Well, now's as good a time as any. You tuck the patient's chart under your arm, you walk down the hospital corridor to your patient's room, going to break this bad news. As you reach out with your right hand to push the patient's door open, you feel a tug on your left arm. You turn and you see it's your patient's adult daughter. The daughter says, "Doctor, I won't tell you how I learned this, but I know what you're going to go in there and tell my father. I can't let you do this, especially not today." At this point, the question stops and says, what should the physician do or say next? Well, the option you see there that says to her, "I'm sorry, but it's important that your father know this information, leave her behind and walk into the room," that's not correct. Because that was you being carried by momentum, simply executing your original plan. She stopped you. Something new is in play. Throw out your old plan. It's time to make a new one. Now, what's a good new plan? Well, the option that says, go with the daughter off into a side room, discuss her father's health condition, and when she's calm, go in and talk to the father, that's clearly unacceptable because that breaches confidentiality. The option that has you taking her into the room with you so he can benefit from family support while he hears this difficult news, that's clearly unacceptable. That breaches confidentiality. The right answer here is turn to the daughter and say, "Tell me more about why you don't want me to tell him this information today." Notice what's happening. I'm not giving, I'm getting information. Again, I'm being that information sponge I talked about. Because let's be clear, is there anything she's going to tell me that's going to stop me from walking in that room and telling him his diagnosis? The answer is no. But is there anything she might tell me that might change how I handle things when I walk in and tell him his diagnosis? The answer to that is, of course, yes. The question is not why should I ask the daughter what's going on? Why wouldn't you ask the daughter? When this new information is available, literally in your face, why wouldn't you take the time to collect this new information, which might alter radically the way you'll handle the situation as you go and talk to the patient? Number 8, now the rules get a little bit tougher. Always admit when you make a mistake. When you make a mistake, you will tell the patient that you made a mistake. And in fact, this rule is actually harsher than it first appears. The real rule is everything that goes right in the treatment of the patient, it's because I belong to this wonderful medical team. I belong to a team of these wonderful professional healthcare people, and it's the cooperative effort of all of them that produce this excellent health outcome. Anything that goes wrong in the treatment of the patient, your fault. I don't care who does it, it's your fault. If a nurse forgets to put something in the chart and that leads to a bad decision, it's your fault. If the pharmacology that was administered was inappropriate, it's your fault. If a medical student goes and gathers information and brings you, for example, the wrong lab values, it's your fault. And any presentation to the patient other than, "I screwed up," is unacceptable. You have what we call captain of the ship responsibility. That means you're ultimately responsible for everything that happens in the treatment of your patient. Captain of the ship responsibility. If the lowliest seaman down in the engine room, in the deepest part of the battleship, drops a wrench and the battleship blows up or something else terrible happens, who's responsible? The captain is. You're the captain, you're responsible, and that should be the conversation. If the medical student brought you the wrong lab values, and because of that, you've now put in place the wrong diagnosis and arranged for the wrong treatment, when you discover the error, you must go in and tell the patient about the error. But the presentation cannot be, "I'm sorry the medical student brought me the wrong lab values." The presentation must be, "I'm sorry I screwed up. Here's the problem." I like to call the exam cheap heroism. Open your arms, take the arrow on the chest. Because it's all hypothetical. There's no real legal liability here. There's no real damage or danger to you. Do the right thing. If something happened that was wrong, we tell the patient, we admit the mistake. We've successfully completed a difficult surgical procedure, and now the patient is sutured for closing. As we're beginning to organize ourselves to leave the operating theater, the nurse counts all the different instruments and paraphernalia, as is customary, and she discovers, to her agitated horror, that we're missing a sponge. I put my head together with the surgical team, and we figure out where the sponge likely is. We snip the sutures, go in, there's that sucker. And now we resuture the patient. Everything's fine. The patient never need know. Right? Wrong. Tell the patient we had a successful operation, although we did have to go back in and retrieve a sponge that we neglected. Absolutely, positively, tell them exactly what happened, exactly what you did. This is nothing more than an emphatic application of what we said before. Tell the patient everything. The good, the bad, and, of course, the ugly. Number 9. Number 9 is an easy rule, one that I hope will guide you through a lot of difficult waters on the exam. The rule here is never pass off. Simple. It's your patient. You deal with it. So when do you do a referral on the exam? The answer is, you don't. It's not that referrals are bad medicine. They're not bad medicine. They're fine medicine. Just referrals are bad exam answers. See, the exam wants to see how you make a decision. Make the decision. So when do you do a psychiatric referral? You don't. You deal with whatever you're presented with. Assume if you're presented with it on the exam, we expect you to handle it. Assume we will only present you on the exam with things we think you can handle. Your job, handle the situation presented. The rule we had previously in the ethical legal section about not going to court is simply a variant of this never pass off rule. You sit with the patient, come up with the solution, solve the problem. Don't pass it off to somebody else. As a part of that, I'm going to give you a corollary, which is never leave the scene. If you leave the room, I can pretty much guarantee you got the question wrong. If you have a hostile, aggressive patient, you don't leave the room, you stay and you calm the patient down. If you have people that are angry and throwing things, you don't run away, you stay and you get the situation to be calmer than it was before. Leaving the room is not solving the problem, it's avoiding the problem, and avoiding the problem will not get you the right answer on the exam. Number 10. Number 10 is one of my favorite rules in this section. It's a great rule because it not only helps to guide your thinking going through the exam, it's also a wonderful rule to handle patients in the real world. This is how you're going to deal with every angry, hostile patient or family member that you encounter. The rule is express empathy and then give control. Please note, both must happen. One is not enough, you must do both. Express empathy, give control. Prototypically, it's as simple as, I'm so sorry, that sounds terrible. What do you think we should do next? Express empathy and then give control. Please notice, just saying I'm so sorry isn't enough. Please note saying I'm terribly sorry, here's how we'll fix it, isn't enough. Please note justifying yourself that the way things are is okay and acceptable and the patient should feel good about it is clearly not the right answer. See, when patients are angry, hostile, when you try to guide them, even in rational ways, most patients simply become more angry. Most people, when they're angry, are not thinking rationally. All they feel is you're trying to move them one side or the other, and they get angry at that feeling of being moved. But when you express empathy, you're recognizing how they feel. When you give control, well, basically you've handed them the steering wheel. And when they're driving, it's hard for them to yell at you for how you're driving. Express empathy, give control. You walk in to see one of your patients, a 68-year-old man who's had rather severe arthritis in his knees and his hips. As you walk in to say hi to the patient is irate. I can't believe you have your office in this stupid location, says the patient. I had to park 4 blocks away, and you know how my knees and my hips hurt. I'm in great pain. I can't believe you put your office in this stupid place. To which the physician's best reply would be, I'm so sorry, that sounds like it's very painful. Let's talk about what we can do so this won't ever happen again. Express empathy and give control. The option you see that says, we validate parking across the street. Yeah, that one's not right. It is a solution, but it doesn't deal with the presented issue from the patient. An option that says, well, I'd be glad to see you a later time in the day when parking is easier. Not the answer either. Why? Because you have to tell them you feel how they feel, express empathy, and then you have to work with them to come up with a solution, not dictate what you think is a good solution.